Welcome to this carotid session. The first presenter is just getting his slides back again. So we're starting with Professor Christos Liapis from Athens, who is well known to all of you, I think. Christos.
Thank you very much, Chair people. If I could have my presentation. Thank you very much. No Islands of Salvation, it's not the title of my talk. It's just that this week we had two important visits in Greece. Greetings from Greece, by the way. Pope was visiting the island of Lesbos, well known to you for several reasons. Recently, for the thousands of people coming over there to find salvation. And then we had, at the same time, the visit of the President of the Republic of Serbia, who came to the island of Corfu 100 years ago. For a less well-known factor to most of us, Corfu was the capital of Serbia for 3 years, capital of Serbia in exile, and it was called afterwards the Island of Salvation. So we have two islands of salvation right now. Unfortunately, it seems like the refugee problem remains the same throughout centuries. Another problem that remains the same is the problem with the strokes and what to do with the strokes. And acute stroke is indeed highly prevalent. Right now, one stroke every 3.5 minutes is happening in the UK, quite high number. And we have, in order to communicate, we have to agree on certain definitions, like what's a recent TIA. It's a single episode, and apologies for repeating all known facts to you, but it's a single episode of TIA which occurred within 24 hours. A crescendo TIA, or 2 or more episodes within 24 hours. A recent stroke is a fixed neurological deficit occurring within the past 5 days. And stroke and evolution is a progression of neurological deficit that had occurred over at least 24 hours. And we have clinical evaluation ways of putting numbers, like the Glasgow Coma Scale going from 1 to 6, then NIH Stroke Scale and Score going from 1 to 11, which it's particularly helpful because it can correlate with the size of the infarction on CTA or MRI. And for scores 1 to 4, we call it a minor stroke, from 5 to 5, a moderate stroke, 16 to 20, a moderate to severe stroke, and 21 to 42, a severe stroke. And then we have the modified ranking scale for neurologic disability, which measures the degree of disability after the stroke, starting from 0, meaning no symptoms, and going all the way to 6, meaning dead. And then we have the ABCD2 score, which predicts which one of the TIA patients will progress into full-scale stroke. Now, besides the clinical evaluation, people over the years have tried to assess severity of score and to see the score progression by using biomarkers. It's a recent paper by our group when we're using novel antipocaines to see whether or not a stroke will progress into something more severe. And we did find that visfatin levels can be a predictor of cardiovascular mortality and morbidity in acute ischemic strokes. Of course, this is a small study on only 168 patients and 58 matched individuals. Now, coming to our subject of discussion today, we do know that carotid endarterectomy in symptomatic patients have been proven, at least in the well-known historic study, to be beneficial, provided that we do have more than 60 to 70% stenosis of the internal carotid artery. And what is of interest is that over the years, we can see an improvement in the results of carotid endarterectomy. It's quite obvious here, starting from 85 going all the way down to 2014, that there is close to be statistically significant improvement in the results. Now, you can argue that this may be due to publication bias, and we only tend to publish our best results. But if we look at what is happening in the results of registries that like this well-known huge German registry, over 52,000 of people for a period of 11 years, we can see definitely here, I draw your attention, the fact that we started with 4.2% mortality morbidity, and we ended up with 2.4. That's for symptomatic patients. I know it's not the subject of my talk, but I cannot go away without pointing out that at the same time, the stroke death complications of carotid endarterectomy for asymptomatic patients is only 1.1%. And unfortunately, nobody talks about this difference when we're dealing what is happening with the asymptomatic carotids. To me, a patient with an asymptomatic carotid with severe carotid stenosis, non-carotid stenosis, who ended up symptomatic and have an operation has been misused from the medical community, but probably this is my own personal bias. So what do we do with the symptomatic patients? Again, carotid endarterectomy, and the sooner, the better. And ESVS guidelines were the first guidelines ever to point out that carotid endarterectomy should be performed within 2 weeks of the patient's last symptomatology. And that was based on the analysis of the well-known historic studies indicating that in the period before the 2 weeks, we have the largest number of recurrent strokes in symptomatic patients. Other studies later on, including TCD studies, indeed showed that carotid endarterectomy 7 days from the most recent symptoms, they do have TCD findings up to 42% and 8 to 14 days, an additional 22%. So we have to do something within the first 2 weeks of symptomatology. So how can we improve the results of endarterectomy in acute stroke patients? Well, usually since medicine is not an exact science, we have to use paradigm from other sciences and scientists like Drucker, who is the guru of running efficiently a company, indicates that efficiency is doing things right, but effectiveness is doing the right thing. So we have to be efficient, but also we have to be effective. And nowadays, technology gives us the tools to be both efficient and effective, like cerebral CT perfusion imaging that can identify a subset of acute stroke patients who benefit from emergent carotid endarterectomy, as we can see here, has a complete occlusion of the carotid, still no infarct, just impaired perfusion, and after the endarterectomy, everything comes back to normal. During the procedure now, the permissive hypertension improves hemodynamics and probably should be used in symptomatic patients. Now, regarding the use of shunt, there are many contradictory views on the subject. Our host here, Lazar Davidovich, who is also very much interested in biometrics, is using serum NSC levels to find, and pointed out that by using routine shunting, he can decrease this specific anolase and protein S100B concentrations in the brain, which is very beneficial for the symptomatic patients. So for Lazar, everybody should be shunted during surgery for the symptomatics. Closure technique after carotid endarterectomy, especially for symptomatics, should always include the use of pads. The size of a patch is debatable. For most of the people, for better hemodynamics, a 5 millimeter patch is also suitable. And at the same time, before putting the patch, you have to rigorously backbleed the internal carotid artery, making sure that all the clots inside the internal carotid have been properly removed. How about now the role of timing for carotid endarterectomy for the acute stroke? Well, there are several differences in European countries, and as you can see here, for United Kingdom, the median delay from symptom to surgery is 11 days, for Germany is 9 days, and for Sweden it's only 8 days. Now, this is not the only difference that Swedes have. Swedes, in the Swedish registry, they found out that if they operate on an acute stroke, within the first 48 hours, the stroke death rate goes all the way up to 11.5%, which is not the case for the other two registries. In UK, it's only 3.7%, and the German registry we were talking before is close to 3%. So something must be going on in Sweden. Probably is a bias in selection the patients. And if we go around the various countries, we have this report from Austria, quite large report in close to 450 patients, and they did find that an infarction on the preoperative CCT leads to an increased risk for a postoperative deterioration after carotid endarterectomy, but endarterectomy within 7 days after the neurological event is safe and effective in stroke prevention. In a study from France, a smaller study, it's only 27 patients, but again, excellent results provided that you have quick neurological evaluation, immediate start of secondary stroke prevention measurements, optimal perioperative medical treatment, and standardized operative techniques. This is pretty theoretical, but that's their suggestion. Now, from the large USA registry, including more than 27,000 people, they did find out that the optimum timing of revascularization may be near to the end of the first week of hospitalization following an acute stroke. From Italy, Capozia found that, especially for crescendo TIAs, the results of immediate surgery are very beneficial, but as far as stroke and evolution, the NIHSS score should be quite low in order to have good results. And from our host country, again, a small study, 70 people, about the same results, excellent results with crescendo TIAs, not so good results with stroke in progression. How about the general speaking preoperative management? It's general belief nowadays that besides aspirin, we should also use clopidogrel and statins preoperatively in all these patients. And recently, what we always feared for years, meaning the use of thrombolysis before carotid surgery, is now introduced in large series, like this one coming from the United States. And it was found out in the Osner clinic that thrombolysis followed by urgent endarterectomy is not associated with an increased risk of complication. What is most important, they found out from the same clinic that collaboration with vascular neurology team increased the volume of urgent carotid endarterectomies and improved the results. So coming to my conclusion, I believe that acute stroke is still highly prevalent, that in patients with mild to moderate stroke, meaning NIHSS stroke rate less than 10%, and a significant relevant carotid stenosis, urgent carotid endarterectomy has excellent results, but CT perfusion of the brain and the biomarkers can help in patient selection for emergent carotid endarterectomy. Within 7 days after acute stroke, probably is safe, but time is brain. We have to be quick, but we have to use our brains not to look at the clock all the time. Stroke and evolution and crescendo TIAs need emergency surgical treatment. Intravenous thrombolysis is offered to an increasing number of patients suffering from stroke. It does not seem to influence the risk of major complications for carotid endarterectomy. Most importantly, the treatment of stroke requires multi-specialty approach, a stroke team, and the vascular surgeons should be part of it. Unfortunately, in many European countries, vascular surgeons are not part of the stroke team nowadays. And the literature is characterized by few studies with small series of patients, registry-based studies, and as always, we are in need of RCTs. Thank you very much for your attention.
Christos, we're a little bit behind. I just wanted to ask you one quick yes or no question, and that is, surely the results, the improvement in the results of surgery are really due to statins?
I did not say that.
No, I know you didn't say it.
Yeah.
So do you agree or not?
Not solely to statins. It's a general healthcare improvement, the exercise, the statins, the antiplatelets, the better the cessation of smoking and better control of the blood pressure. I would never attribute everything to statins.
Right. Thank you very much, Professor Liapis. And we start with the first presenter who will replace Professor Setacci. And I'm sorry, I don't know your name. Calzerano, Dr. Calzerano, and he's going to talk about common carotid practice in 2015.
Okay, so good morning to everybody, dear moderator, dear colleague. First of all, let me to apologize Professor Setacci to not to be here and apologize myself to replace my mentor only as well as I can. So, as you know, VASCUNET is a subcommittee of the European Society of Vascular Surgery, which aims to increase knowledge and understanding of vascular disease and to promote excellence in vascular surgery by means of international vascular audit. As I think all of you know, audit is essential to the maintenance of good clinical practice, especially in surgery, where our outcomes are dependent on the careful selection of the patient and on the skills of the surgical and anesthesiological team. It is important for surgeons to share their data and their results and how these compare with others in their fields. This is the VASCUNET members, and I want to start with some concern about the registry. As you know, not all countries included the data and are analyzed in the VASCUNET registry, and moreover, even in the most efficient nation, not all centers include data in the VASCUNET. Look at the Italian condition. We have a national registry, the CREST, on the Italian Society for Vascular and Endovascular Surgery, but the data is actually excluded from the analysis. And moreover, in Italy, not all vascular surgery centers include data in the CREST. So we are obviously working on it, and we hope to improve our performance in sharing data in the next few months. Then we have to say that not only vascular surgeons treat carotid stenosis, so the data are not available to show us the general practice. And the preliminary conclusion on these preliminary findings is that the VASCUNET is almost incomplete, that has a bias in presentation of general practice, because we need to consider the interventionalist data and also some data from cardiac surgery and neurosurgery that face some days in their daily activity the carotid stenosis. Moreover, the data analyzed are up to the 2013, and the question of this topic asked the common practice in 2015. However, there are some good news. For example, the International Consortium of Vascular Registry, that is a platform, a collaborative platform, through which registries and other stakeholders around the world can share the data to improve vascular and healthcare. But I have to say that also the highly advanced United States provide about the 20% of data out of all the procedure. However, jump to the data. And regarding the use of carotid endarterectomy in comparison with carotid stenting, this is the data provided by the ECFOR about the 3 years from since 2010 to 2013. This is the global data, and as you can see, we have a very important prevalence of carotid endarterectomy, about 90% of the procedure. And this rate increase if we look only at the European included data, we can say that we have only the 6% of patients treated endovascularly. These graphs show us as what is the case rate for every center, and every circle has a center. The bigger circle represent many higher level of data. You can see that the CAS rate is higher in the United States registry. As summarized in this table, you can see a 10% of median of CAS in the ECFOR globally, but US centers that are listed below, in the below part of the graphs, have a higher rate. Look at the Italian condition. This is the data from the Grego of the last 3 years. We have recorded more than 16,000 patients treated for subaortic vessels pathologies, and endovascular tools are used in 14% of the patient. Regarding the demographics of the patient, the majority of patients are obviously over 65 years old, both for CAS and endarterectomy, as summarized in this table. Stroke history is similar in the two techniques, but more interesting is analyze data about symptomatic patient. As you can see, European center that include data in the VASCUNET treat more frequently symptomatic patient, while the American center treat more frequently asymptomatic patient, with a median that is around the 60%. The level of symptomaticity is similar for carotid artery stenting, and maybe the United States center treat a higher rate of symptomatic patient with endovascular tools. Regarding cardiac disease history, you can see that the level is lower in the carotid endarterectomy series in comparison with carotid stenting 1. General anesthesia is widely used around the world, and the data provide that more than 80% of patients are treated with the general anesthesia, particularly in the US centers that you can see listed in the lower part of the graphs. Obviously, use of shunt depends on type of anesthesia and type, and have a very high rate of variability in each center. And interestingly, there are a big use of general anesthesia in endovascular procedure. In the majority in the US, some centers reached 20% of carotid artery stenting in general anesthesia. Eversion has the same variability of shunt use. It's interesting that in Hungary, the majority of the procedure are performed with this technique, and obviously in Hungary the patch is have a lower use. Regarding data provided, since this very interesting meta-analysis of 2011 on RCT available at that time conclude that for every 1,000 patients opting for stenting rather than endarterectomy, 90 more patients would have stroke and 3 more patients will be dead, but we observed 10 fewer MI. However, very recently, the published 10-year result of CREST show no significant difference between carotid artery stenting and carotid endarterectomy with respect to the primary composite endpoint. And similar data are from a CT1 result. Obviously, we hope other ongoing trial that could justify and clarify this conclusion. So as you know, we can say that the main difference between carotid endarterectomy and carotid stenting is in the first 30 days outcome, in which the event occur. So we need new material, in particular new stent that provide better protection against small and late embolization. In our experience with intravascular imaging, we try to define an ideal stent that has to conform to the vessel anatomy and providing an optimal plaque coverage. And I have to say that up to now, this kind of stent is not available, but the new stent design seems to raise this objective. In fact, we have some experience with the road saver stent. As you can see, the OCT image of one result. Okay, so I finished. There is the results of the Italian registry. You can see the findings, procedural findings, and the very interesting results. We hope that trial can clarify better. As you can see, this is our experience. We have a similar early result in 50% of carotid stenting in respect of carotid endarterectomy because a very strictly ruled for CAS selection. So in conclusion, VASCUNET and DCVR reveal an endopathetic attitude of European center. Italian and American seems to be more attracted by endovascular procedure. Cardiac disease history seems to not represent important criteria for surgical strategy, and symptomatic patients are most frequently treated with endarterectomy. At different centers have a different attitude in terms of type of anesthesia, eversion, and patch use. So our personal conclusion, endovascular procedure rate could increase in the next years due to the better material available, but surgical society must pretend the leadership in guideline drafting for carotid stenosis because only tailored procedure could improve the global outcome. Sharing of data is obviously mandatory and up to now is insufficient. Waiting for you in Siena in next September. I thank you all for the kind attention.
Thank you. Thank you very much. You could have used another minute, so we have 1 minute more for discussions. And let me start by just asking you one question. In your center, the CAS, that balance between CAS and CA and endarterectomy was on symptomatic or asymptomatic patients?
We have some experience on CAS on symptomatic patients also. We try to we treat more symptomatic patient with endarterectomy, to be honest, but symptomatic patient has the same selection that asymptomatic patient.
Thank you. Questions from the audience? 2 questions. Short questions, please.
Very short.
Professor Radak.
Okay, thank you for a very interesting presentation. And now we will have a chance to know what does Professor A.Halliday from Oxford is thinking about collaboration in asymptomatic carotid surgery trials.
Thank you very much, Professor Radak, and it's very nice to be here, and it's been a wonderful meeting so far. Thank you. As we know, about 20% of ischemic strokes are due to carotid stenosis, and I don't think this actually works too well, but we know this, I think, and it's why we're in business really doing this. What we don't necessarily know is that, again, we spoke about smoking this morning, my colleague Richard Pito, and this is the relative risk of developing severe carotid artery stenosis if you are a current smoker versus a never smoker. It is 5 times nearly higher than normal, so it's a very important factor. It's also important to retain your cognitive powers. So in other words, it's nice to think that you have the thinking power of a 70-year-old if you're 75, but in fact stroke and TIA cause cognitive aging, and here you can see that the extent of that is somewhere between 3 to 7 years. So it's a serious problem for cognitive aging if you have stroke or TIA, and carotid disease is a serious problem. So most patients find it very difficult to stop smoking, and a lot of them don't take the drugs they're given regularly. But of course, the advantage, or one of the advantages of CEA and CAS, that once you have it, you can't take it away. You get 100% compliance, and when you've had it for life. So it can be a very effective treatment if it doesn't cause problems. Originally, we asked whether it was worth doing the operation in people with carotid stenosis to prevent stroke in the future. And we looked at just over 3,000 patients, randomized them, very nice, randomized them between having an endarterectomy with medical treatment or just sticking to medical treatment alone. And eventually we found, with all the help from the 30 countries that took part in this, that in these patients, and plenty of them came from Serbia here, 77, that the answer at that time in the mid-2000s and later in 2010 with long follow-up was that carotid surgery saved strokes. So despite the 2% risk, which was on patients with statins, it still produced a useful reduction of your chances in having a stroke in the next 10 years of about half. Unfortunately, we used the wrong name for the trial because although the patients didn't have symptoms recently, actually 40% of them had had symptoms or endarterectomies or CT infarcts in the past. And these patients had a somewhat higher risk, about 50% higher, of having a stroke if they didn't have an operation done early. So there are higher risk groups, as we've heard from other speakers and we'll continue to hear, and certainly having had previous infarcts or symptoms makes you a higher risk patient. Well, after we published these findings, we turned to the question of whether, if you're going to do something or you think you need to do something, which is better, surgery or stenting? Well, we all know the advantages that stenting offer that the patient sees: no incision, get home a little quicker, less likely, much less likely to have cranial nerve damage. And actually, if stenting was as safe as surgery, there's no doubt that patients would opt for stenting. There are lots of guidelines, and without reading all this, I can assure you that the guidelines give mixed advice. And when you've got mixed advice, you've got uncertainty. When you've got uncertainty, that's the time for a trial to try and see things more clearly. Very important, as just mentioned, is the evidence from the long term. Very short-term evidence isn't nearly as helpful as long-term evidence. So we had 10-year evidence from ACST1, and there is evidence from other studies. And we mentioned ACSRS, in where you're comparing people with symptoms having stenting or surgery. Same question, and the early results put people right off. More minor strokes. So certainly in the UK, people almost stopped stenting. Quite a lot of centres stopped, others carried on, results improved, the devices also improved, and the 4-year results were a different story. And the results that were reported then show the modified Rankin scale, as you see here, in both the stented and the surgical patients at the end of follow-up at 4 years, and that's continued. are pretty identical. So despite the early minor strokes, the long-term results seem to be similar. So we have reduced procedural risk, which we felt is certainly partly due to statins for endarterectomy, and now we have reduced procedural risks for stenting. And that is because the techniques, the devices, and the experience have all changed since the early symptomatic trials when there were more minor strokes. We now have flow reversal systems, direct puncture, membrane stents, and we have actual objective evidence that some of these newer devices, used responsibly, will reduce the risk of distal embolization. Most of us know about the structural difference between open on the left, open stents like the wall stent, closed cell stents like the wall stent, and on the right, open cell stents. And that extra free cell area, as you can just about see here, means that as the stent opens, you have the possibility of extrusion of the soft plaque particularly. And there's been a lot of worry about that and some suggestion that the results are certainly worse for particular plaques. There are hybrid stents, there are membrane-covered stents, there are reversal flow devices, and now you have direct puncture techniques as well with new stents. So you have, in fact, a whole different idea. And that question, which procedure is better, if you're going to do one procedure, stenting or surgery, could well have a completely different answer in the future. So we started doing this trial, and certainly there's no doubt that the experience that people had, as you see for CEA, a median experience of 17 versus 11 years, that's a lot more experience than they had with the early trials. So there's better experience for both procedures. Now these are the types of stents, for example, that we now have in the trial. In the pink, you can see the closed cell stents. The wall stent is still the most popular. Then you can see open cell stents and the numbers so far, hybrid stents, and the beginning of the membrane stents coming into this. So we still have a period of time to go to recruit, to get these different devices put in by more experienced operators. And the use of cerebral protection devices we're monitoring very carefully. You can see they're divided here into filter, proximal and distal, and 14% of people who don't use them. These are mostly neurosurgical centers. The types of patients we have, compared with the first trial, a little bit older, but there's a lot more diabetic patients. There's a quarter of the patients who are older, over the age of 75, and there's another 43% of these patients who've had previous symptoms, so they could be a higher risk group. But it's certainly not a completely, totally, always asymptomatic trial. At trial entry, they are on very good medical therapy. Lipid lowering, 85%, antihypertensive, 88%, and 98% antithrombotic treatment. And we get results at 1 month after surgery and later. So far, we know what drugs people are on. We also know at annual follow-up what they're taking. And we know that for the two procedures combined, and we are about to have this year's data monitoring committee, and the disabling and fatal stroke risk for both procedures combined is still 1% or slightly lower. Today we have 2,161 patients. CREST, the other trial which is going on at the moment, and SPACE 2, which has stopped, had a similar design, a design similar to ACST1, stenting versus medical treatment alone, endarterectomy versus medical treatment alone. So more information will come from SPACE, doing longer follow-up on the 500 patients they have, and on CREST, which is still very much in the early stages of development. They have about 200 of 2,400 planned patients. We have a very European trial. We will get a really large group of trials together. And finally, what we will have then is this whole series of Act 1 and ACST2, comparing the procedures, and then procedures versus medical therapy with the other trials, and a total of 5,000 or 6,000 patients. And this is why good collaboration, bringing all these patients together, will answer important questions like how important are current medical treatments, how important is the greater operator experience that we now have, especially with CAS, and perhaps what difference is there with different types of devices in broad categories, but also in the older but often fitter patients. And we still will be going for another 3 years in recruiting patients. So please consider joining us if you haven't done. Thank you.
Alison, thank you for this beautiful overview of asymptomatic carotid surgery trials. And I would like to know, what would you do if somebody would invite you to make a design for the study about cognitive deterioration of the asymptomatic patients?
I get some knowledgeable friends together. So because it's quite complicated, and Athanasius is certainly sort of interested in that as well. But we are going to look in a very broad way at the very, very long-term follow-up of 1,600 patients from ACST1, the Swedish and the UK patients, to find out what the outcome 16 to 22 years later is in terms of the development of dementia in those groups, the group that had the endarterectomy versus the others. I think the process of actually designing prospective trials to look at this, you've got to, exactly as Athanasius said the other day, you've got to decide which tests you're going to use, you've got to decide what they are actually measuring, and they have got to be applicable not just to the immediate post-procedural thing, but actually to the long-term development of dementia.
Also, if I can go further this question, we need to have an age and gender matched control group without having carotid artery stenosis to find out after 2 or 3 years what's going to be the deterioration of their cognitive status, because this might be due to the human nature and to the aging of the population. So it's a very difficult issue to be investigated. And everything should be carefully designed and on a prospective basis. Otherwise, we are going to add to the conflicting existing evidence for the time being.
Do we have some other questions? Thank you.
So, the next speaker is Athanasius, that will speak about retinal infarcts after carotid intervention in asymptomatic patients should be used as a surrogate endpoint in future trials. Please, Giannoukas.
Mr. Chairman, ladies and gentlemen, first of all, I should like to thank the organizing committee for including me in this special program regarding the carotid artery disease. These are my disclosures. And I would like to bring to your attention an actually very neglected issue. Retinal embolization during carotid procedures. Is this a myth or reality? We know that microembolization occurs more after carotid stenting, less after carotid endarterectomy. And also, in carotid stenting, this happens even with flow reversal brain protection devices. And this is an important issue because the embolization, along with the presence of pre-procedural brain infarcts, may consist the basis of predicting patients at high risk for adverse effects. Retinal embolization during CAS is not uncommon. As you can see from a publication back in 2010, and it occurs in both protected and unprotected procedures, detected by fundoscopy only. But in this particular study, it was concluded that most of the retinal emboli were clinically silent based on the visual field testing. I would like to show you a few pictures of our cases which surprised and stimulated us to look at this particular problem. This is a fundoscopy, and you can see these white spots inside the retinal circulation, which represent infarcts after carotid stenting, which it is something that probably the vascular community thinks that it doesn't happen because they never looked about that. And look in this fluoroangiography picture, which shows that there is blockage of the peripheral circulation of the fundus. Carotid stenting, in fact, has over the last years emerged as an alternative therapeutic option to carotid endarterectomy for the management of carotid artery stenosis. And especially in respect to the asymptomatic patients, we have several randomized control studies which compare the efficacy of carotid artery stenting versus carotid endarterectomy. And mostly the outcomes have been based on the presence of neurologic events and death and myocardial infarction. The rationale to look at few different issues, I think, is very important. And it's very important because what it is, my perception, I think it is the perception of most involved in current carotid trials, is that probably the difference between the two interventions in the asymptomatic patients, based on the currently used endpoints like neurologic events, myocardial infarction, TIA, probably it is not going to show any major difference. And we have a clue from what Alison showed us as the first results from the ACST2 study, which the incidence of neurologic events is quite low. Therefore, I think that probably if you would like to see what is the impact of these interventions in asymptomatic patients, probably you have to look at different issues. One is the cognitive function, which is very important, as well as the retinal embolization. And it has a rationale, because visual acuity and visual function are important parameters for the quality of life of elderly patients. And if this happens, is associated with anxiety and depression. Imagine that if you have a purely asymptomatic patient which may never experience for the rest of his life any neurologic event, you go and intervene, and at the end of the day, you leave him with impaired visual function, which will make definitely the quality of life much worse as it was before the intervention. Therefore, I think that to look at the eye-related quality of life may be an important denominator for the asymptomatic patients. And that's why I think that in view of the currently existing ongoing randomized trial, probably this could be included as a part of a little sub-study. It is difficult to identify what are the numbers needed beforehand, because we don't have numbers to make any power analysis, but arguably, based on the evidence we have that brain embolization is a common phenomenon, I would speculate that probably retinal embolization should be a very common phenomenon. Probably 100 patients in each intervention arm would suffice, but it can be a readjustment in the numbers needed after an interim analysis when 50 patients may be collected in each arm. And the aim is to investigate, in fact, the result of the ophthalmic circulation in the outcome of visual function in patients, probably when I did this proposal to the ACST2. You can see that the protocol can be quite simple. 1 or 3 days prior to intervention, visual field testing, bilateral fundoscopy with a digital photography, and optionally, bilateral fluoroscopy and angiography are the investigations needed. 2 or 3 days after the intervention, bilateral fundoscopy with a digital photography, and again, optional bilateral fluoroscopy and angiography. And 6 months later, after the intervention, visual field testing. But again, in each study, the financial matters is a very important issue. It is difficult to adapt what is going to be the cost added to the patients included in any randomized study in each country, but I did a calculation in the Greek reality. And you can see how is the cost of each of the involved tests. And if you sum up all these costs, you can see that the full total cost without fluoroscopy angiography is about 180 euros, which compares favorably with just one brain MRI, which costs 240 euros. Therefore, I think that this is feasible and is something which is needed in order to show differences in patients on whom probably, based on the currently used criteria, we'll never find any difference between CAS versus carotid endarterectomy. I should like to thank you for your attention, and you are invited to attend the live meeting next month in Ioannina, Greece.
Thank you, Anastasios, for your nice work. There are some questions on the floor? No, I have a question for you.
Please.
I think that probably it's true that is a common the number of the microumbilical phenomena of the retina, but it's the different time if you put in relation carotid endarterectomy and carotid stenting, because the number of the microembolic phenomena probably in carotid endarterectomy is during the isolation of the carotid artery. Instead, the carotid angioplastic stenting probably is during the time when you take out the filter. And so in the future, in the long-term results, after 2 or 3 days, you think to do an fluoroscopy. Probably it's better to do another fluoroscopy after 3 or 4 months to have a good relation between the two techniques.
It is true, but if you want to keep the whole protocol quite cheap and applicable, because it is a little bit laborious, the fluorescent angiography, and is not without as any kind of angiography, without any kind of complications. And based on the couple of publications which show that the emboli disappear as the time goes, probably you will not find any meaningful information regarding the angiography. But what you can find is the difference in the field testing. And that's why I think that is more applicable to find, to check after, let's say, 3 times, and this is 3 months, and it's very important because you don't have to have a too short follow-up, not too long follow-up, to find out what is the impact of these emboli once they happened, and once you have confirmed it 2 or 3 days after the intervention on the visual field testing, because this is the important issue which relates to the quality of life of the patients.
Professor Liapis, please.
Excellent presentation, Professor Giannoukas. But I have a practical question. Quite often during CAS procedures, the patients are complaining of this flashing while we're injecting the dye in there. And most of the time, the radiologists will say, okay, it's just an irritation of the dye, things like that. You think this is actually emboli? Can you distinguish between this effect of the dye and the actual embolization of the retinal circulation?
Christus could be both. Could be the effect of the dye injection, could be due to the shower of microemboli, especially if this happens with just some kind of impairment of the cognitive status of the patient at that time. It might coexist with a shower from microemboli, but it could be both.
Can I just ask you one point is related to the size of the emboli in the retina. Is it correct to assume that there are smaller emboli than that goes into the brain? First question. Second, have you tested with your observations that it can be detected with transcranial Doppler as well?
Certainly, emboli can be detected during the procedure with TCD. The problem is that you never know with these emboli detected by TCD which amount of the emboli go to the brain, which amount go to the retinal circulation. What is very important is to confirm that you have retinal embolization after any kind of intervention, SER or CAS. If this is confirmed, then you can, provided that you have enough numbers, to differentiate what is the impact of the centrally located versus distally located infarcts in the retinal circulation regarding the visual function impairment. But I don't have results to tell you anything about that.
But can I ask you another question, which is out of my ignorance? Will it be possible with a probe applied over the eye to detect embolization the same way we detect it for the brain, for the hemispheres?
To the best of my knowledge, I don't know any kind of device which could be applicable during the intervention. But let's think in a logical way. What would be the meaning of this? It is just to detect. But otherwise, you will proceed with a planned operation or planned intervention, and then what you would like to see is what is going to be the effect of your intervention.
Right. I think we have to discuss it later on.
Okay.
Oh, it's a nice proposal. I think it should be taken into consideration because it's really, you draw attention to one major problem. Loss of vision is really a terrible thing to happen. Thank you very much.
Thank you very much, Jose.
And can I introduce Professor Radak? I haven't seen him for many years, so I'm glad to see him again in good health and good shape. And he's going to talk about 14,000 eversion carotid endarterectomies. So, Professor Radak.
Thank you for so nice introduction. I'm coming from Dedinje Cardiovascular Institute in Belgrade, so I wish you all the beautiful days in Belgrade. I wouldn't bother you with the diagnostics. We have a long story dealing with carotid surgery. We accepted the eversion carotid endarterectomy very early in 1991. And after this, we have had, this is the example, I don't know if it is functioning, transection of the internal carotid artery on the place of bifurcation, eversion, and the removal of the plaque, which is very simple and quick. So we have a chance to decrease the clamping time to approximately 8 minutes with a very simple reimplantation. In this way, we have very good results because eversion endarterectomy, due to our experience, has some advantages, so we very quickly come to a situation that we have more than 1,000 carotid reconstructions per year. And at this time, we started a collaboration with Professor A.Halliday during the asymptomatic carotid surgery trial 1. And we have some idea to do a prospective database dealing with all carotid patients that we receive to our clinic. It means that we have to follow patients with best medical treatment, stenting, and operatively treated patients with follow-up every 6 months. And this is the first page. This is the desktop of this database, which has many pages post-operatively. And this was very interesting because this gives us opportunity to have a single center experience, which is, so to say, quite in numbers. So we know that our mortality declined over time to 0.7%, morbidity to below 3%. We have published it stating that eversion carotid endarterectomy is crucial to have a good mortality and morbidity. We were very optimistic. Then we introduced a near-infrared spectroscopy for intraoperative monitoring of cerebral tissue oxygenation because we were thinking what is the best way to protect the patient if you are doing eversion technique, however, with short clamping time, but is there a need for a shunt or not? So we concluded that question whether regional or local or general anesthesia should be applied should to be very individual, and that there are some neuroprotective role of propofol on sevoflurane. We applied even anesthetic preconditioning for a brain ischemia, and we have published this also in angiology. Another question was, is it dangerous to do a carotid surgery in stroke in progression? And the answer is yes. The much better indication is crescendo TIA, but in the first 6 hours. And this was also the part of those data which we now take out from this database. In the cases of very big damages done by the previous episodes of cerebral ischemia, it's good to do cerebral vasomotor response measuring, so to have some information should or could this patient have a beneficial effect from the revascularization. The new era became with multi-slice CT angiography of cerebral arteries. Now we are doing it routinely to all the patients, and it's very interesting that very frequently, it means in almost 20% of patients which are planned to undergo carotid interventions, we have simultaneously cerebral aneurysms, which was completely new finding for us. We have published it in angiology, and it made us aware that we have to do something for those cerebral aneurysms, and we have now a good collaboration with neurosurgery and a special protocol dealing with the problem of simultaneous cerebral aneurysms. Post-operatively, we have to follow the patients every 6 months to discover restenosis. It's interesting that we have impression that inflammatory markers as high sensitivity CRP, fibrinogen, and C3 unit of complement has a significant role in bringing predisposition for restenosis. Dual antiplatelet therapy is always necessary, but it's better. There is a better way to do a genotype testing for measuring the therapeutic response. So you have a chance to see if acetyl salicylic acid is not necessary, or clopidogrel, for a group of almost 10% of the patients, because they are not responding. Statins, of course, are proven to be necessary. Metabolic syndrome in our patients is very interesting because this is the only risk factor which brings premature atherosclerosis, but at the same time carotid restenosis. And a special role is noticed to be dedicated to oxidized LDL. It could be almost treated as special biomarker for cardiovascular disease. Concerning the stenting of carotid arteries, we are doing carotid stenting in randomized patients for asymptomatic carotid surgery through 2 trial, in the case of hostile neck and in patients with poor general conditions. Especially good results we have with dilation and stenting of the proximal part of subclavian artery and with vertebral arteries in high-grade stenosis. It's very interesting that nowadays we have forgot to redo carotid surgery because it is the best indication for carotid stenting, but there are also some problems, some limitations of carotid angioplasty. This is that it is almost prescribed for elderly patients, and there are also some situations in which stenting is not feasible. In a case of segmental occlusion of carotid artery, in King's coils and massive calcifications. After the stenting, when we have thrombosis, which is very rarely, there is a chance to apply a surgery and to remove the problem, almost always the thrombosis. In any case, endovascular procedures should not to be looked upon as concurrent, but they have to be accepted as complementary to carotid surgery. And we have done many patients in which combined procedures have been done. It means carotid endarterectomy plus PTA of brachiocephalic trunk, or the first part of a common carotid artery, and the results are impressive. The problem is that from this database we also cannot take some valuable responses about cognitive and the emotional deterioration of our patients. But we have done one study about the quality of life, and the quality of life is improving after carotid revascularization. It's very interesting that we have had an idea to investigate the plaque for itself, to see what is happening in the loco of atherosclerosis. So we have done some measuring of copper and zinc concentration, some enzymes. It's a very interesting story, but I think not for this opportunity. And it was interesting to study in loco of atherosclerosis inside of carotid plaque gene polymorphism. What genes are included or active in the carotid plaque. These studies were published in atherosclerosis. It's a very interesting concept, but I think we don't have much time. Thank you.
Can I ask a question? So, just the first question I was going to say, the mortality, George, went down from 2% to 0.7% in the patients over the period of time you were measuring. What do you think were the factors that caused such an enormous improvement in the mortality during your series?
Mortality in carotid surgery.
Yeah.
This is an interesting question. We were thinking that it would be interesting to do a review because when you look at the guidelines, you always have impression, and neurologics have impression that the mortality is not so low as it is, because they are in guidelines. Usually we have not so new numbers. Those days we really have mortality which is years ago below 1%. And I think it has to do with high volume, with learning curve.
Yeah, I think Professor Allison is expecting a different answer.
I don't know what answer I'm expecting, but what I really meant was
Statins.
what's the cause of death in most of them? That would be interesting to review, to know whether it was fatal stroke or
Yes,
just heart disease.
Yeah. You mean in so big group of the patients? Yes, it's very, and we have published it, the causes and how to treat the perioperative stroke. Usually it is the problem with early thrombosis or embolization intraoperatively. We know that this is, it should be accepted as kind of surgical mistake, as difficult it can be. And in the first day, we think that it's very important to accept it and to open those patients again as soon as possible. We think we try to have them again in operatory room in half an hour or less. And the best way, it's very, very important, really, to have them back in operatory room and to remove the blood clots. And there is, I think now more than 20 patients which are saved now due to this urgent re-intervention. At the beginning, it was very difficult psychologically. You always think he will improve, he is not so bad, we will see, he just have hemiplegia, another, he is conscious, but you have to be very critical. It's better to take them back to operatory room and to see that the carotid artery is open than to waste the time.
Only a small question. During your endarterectomy, when you use the general anesthesia, do you use any monitoring system?
Yes, I mentioned it, near-infrared spectroscopy, but not always. Not always.
Do we have some questions from the audience? Yes, Richard.
That's right. Great talk on the value of a large, prospective, robust registry. I do eversion endarterectomies too. The problem I sometimes have in the
Microphone, please, Richard.
I too do eversion endarterectomies under local anaesthetic, and in the infrequent times I need to put a shunt in, that is sometimes a bit challenging when you have detached the internal from the common carotid artery. Do you have any tips, or are you just very quick and you stick the artery back on again?
Yes, I know this. You are right. This is so. We were also very worried because we know that when you are doing this in local anesthesia, you have almost, I think, 6-7% of people having TIA during your operation, and you have to put the shunt. When you are doing the operation in general anesthesia, we believe there is some kind of protective effect of anesthesia, and there are some evidence for this. And we are trying to do a study which could bring us to conclusion to measure the level of oxygenation of the vein blood in jugular vein, and besides to measure the neurohormone, hypophyseal hormones, and to measure oxidative potential of the blood. It's very complicated. We have engaged some people from the biochemistry. I know that it sounds kind of too much, but there is a good, I think not properly used possibility to measure the blood, what is happening in the brain through measuring the contents of the blood in jugular vein. And if there is some protective effect of anesthesia, it has to be shown directly, I think, from the blood from the brain.
Well, thank you. I really wanted to ask a very short question for a very quick answer. If you have a occluded contralateral carotid artery, would you go for an eversion endarterectomy, or will you consider the possibility of needing a shunt, and so we'll change your policy?
For the first years, we are trying to make some maneuvers. Now we are doing always eversion, always quick, and always in general anesthesia, and always without shunt. And I think that it's not the question of being brave, it is something which time brings. When you are sure that you can have a clamping time below 8 minutes, then it's going on. And there is one small trick. You can put him the pressure measurement equipment, which stops the blood in the superior extremities. So you direct the blood, some percent of the blood in the carotid arteries during the clamping.
So fantastic, thank you very much. And Professor Fernandes is going to impart some wisdom now on the next subject. Thank you.
Not wisdom. Okay. Thank you very much, chairpersons. Ladies and gentlemen, I would like to thank Lazar Davidovich for his kind invitation to take part of this meeting. And he asked me to talk about the title on the news from the ACSRS study. I'm not properly the right messenger from that study because I was involved at the initial of the study, but not in the last few years. Therefore, I dare to change the title, Lazar, and I hope you excuse me, to plaque structure is relevant for risk stratification in asymptomatic carotid disease, and I will mention some overview of the impact and the news from the study. I have no conflict of interests, and I would like to remind you some of the established things that were already mentioned. First, from the guidelines from the different societies that recommend asymptomatic carotid disease for stenosis greater than 70%, provided your neurological risk is less than 3%. This probably has to be adjusted. Risk should be lower. And, but these all guidelines have resulted in an excessive number of patients that go to treatment. And we are over-treating these patients. Of course, the great game changer was the stratification of optimal medical treatment. And we have already, this was already mentioned, there was a constant decrease of the risk of asymptomatic carotid disease. And this was related with the best medical interventions, which are well established, and with contemporary medical treatment, perhaps the stroke risk may be less than 1% in asymptomatic, not all asymptomatics. And of course, and Alison has already shown this, there is a group of patients where there is a definitive benefit of carotid endarterectomy, perhaps carotid interventions, despite these patients were on lipid-lowering therapy. So, benefit from early carotid endarterectomy on stroke prevention in all patients, even on patients with lipid-lowering therapy. And the reason was already alluded. Some of these patients may be high-risk patients for stroke, for those who have previous hemispheric symptoms, have a contralateral occlusion, had developed previous silent brain infarcts, or have an exhausted brain circulatory reserve with no autoregulation due to extensive disease. The other point is that we, through the development of the non-invasive technology, particularly with color flow duplex scan and high density, high definition ultrasound, we can look at the plaques, look at the established disease, and realize that not all stenotic plaques are equal, and there is a difference between this plaque, which shows echogenic, which shows uniform structure, to this one, who has a completely different structure. So not all stenosis are equal, and the aim, I think one of the preoccupations was to identify the unstable plaque, that is, the plaques that could develop symptoms and could be related either to the progression of the disease or the appearance of thromboembolic events. And we also knew from the pathological studies that these markers of vulnerability of the plaques are listed here, and they all played a role in the appearance of symptoms. So I think that was the rationale of the ACSRS study, is to identify the unstable plaque, or the plaque prone to develop symptoms, and see if that would enhance the possibilities of right diagnosis and of a better stratification of patients, better selection for those who needed treatment. The ACSRS study was conceived, I think, in the late 80s, beginning of the 90s, took place in the 90s, and it was an international multi-center study, which was initially based at St. Mary's Hospital, now is double-based London and Cyprus. It's a natural history study, which aimed at least to have a 4-year follow-up. And the patient selection was based upon the degree of stenosis as assessed by color flow duplex scan, The clinical information of the patients was recorded, including the state-of-the-art medical management, and all data was collected at the core laboratory and was available for further evaluation according to technological development. Well, it was interesting that this was an important achievement of the study, was the standardization of the measurements and the classification of the severity of stenosis. And that was important. At the same time, the standardization of the plaque morphology evaluation with computer-assisted techniques and the centralized evaluation. We were already aware of the different behavior and the different classification of plaques according to their aspect, to their pictures on the high-definition ultrasound. And there was even a qualitative classification, the gray wheel classification, but it was qualitative. And with these technologies, we're able to put a number and an objective assessment of the echogenicity of the plaque, and that was GSM, and ACSRS played an important role to standardize the measurements, and these were different. Echolucency, the threshold is debatable. Echolucent plaques corresponding to hemorrhagic plaques with hemorrhagy and higher lipid content, echogenic to fibrous tissue or calcification. And we, in a cooperative study with the group in Malmö, in Lund University, have demonstrated also that the echolucent plaques have a different biochemical composition, suggesting a more prone to activity. It was interesting to look back at the value of the GSM. And the value, and several studies have shown that is an increased relative risk, as is represented here in this slide. And GSM on itself increases the risk, or seems to be associated to an increased risk of stroke. But it's more than that. GSM measures the overall echogenicity, and things are a bit more different. Look at this plaque, which is more complex. It was associated with a major stroke because it's the different heterogeneous plaque, very severe stenosis, and compared with this one, which is also a bit not that echogenic, and it was a completely normal, smooth surface, and the patient probably did not require an operation. We looked to the structure of the plaque based on the information we had from the pathologists, and who showed that the important issue was the location of this lipid core close to the endothelial surface. And we could mimic that with the echo Doppler, with the echo high-definition ultrasound, and show that more than echogenicity is the state of the echogenic cap and the presence of an ulceration and the location of the juxtaluminal black area of the echolucent area that was really important and mattered. And we built that within a measurement of activity that we called activity index. It was published many years ago. And this took into consideration several parameters. It is already published. And we showed two things. First, symptomatic plaques had a higher activity index. And second, using the database from the ACSRS study, we could predict those plaques who developed strokes, who developed symptoms. So there was a tool that was expanded by the group of the ACSRS study, who looked into the size of the juxtaluminal hypoechoic area and found it was more common in symptomatic plaques than in asymptomatic plaques, and also found that it was a correlation of the juxtaluminal black area with the stroke-free survival. So then it was a single parameter that could determine or could inform us about the prospect of the plaque to develop symptoms. There we go to the results, and the study was published in 2010, And it included very significant, following significant parameters: echogenicity, heterogeneity of the plaque was quantitatively measured, the just luminal location of the echoluscent area, degree of stenosis, hypertension, and other clinical data. And the importance of this study was that they were able to stratify the risk of, at 5 years, the 5-year stroke risk of these 923 patients in the following groups: 5%, a risk of 5% in 5 years, less than 1% a year in 495, 5 to 9.9 in 202, 10 to 19 in 142, and greater than 20%, that means more than 4% a year, in 84. The message is that we could identify an annual risk group of a subgroup with an annual stroke risk of greater than 5%. And meaning that in 800 patients, we could have said, if we were to apply the rules of the guidelines, that these patients had a 70% stenosis and will deserve an operation or a treatment, an intervention, we would have done 800 excessive procedures. So that was an important information. And this is what showed that the accuracy of the selection, of the stratification, improved this selection of patients, the eventual selection of patients for intervention. And the group also took this further in studying prospectively what happened in asymptomatic carotid plaques, in order looking at the parameter that we have described, the just luminal hyperechoic area, and they found they were able to stratify the stroke risk and identify this higher risk stroke for stroke in between 6 and 10%. And also, this is a single parameter that could be used to select the asymptomatic patients at the high stroke risk for carotid intervention. Well, why is not this pervading the status of assessment and the use of this technology in the trials, on the ongoing trials? Because there are problems which are related to the evolution of the advanced image processing and the analysis methods, the difficult to have standardization and to the need for external validation, the fact that it perhaps takes more time in comparison with the standard evaluation. So the idea was to improve the technology and to develop semi-automatic quantification with the developments of software and improve the analysis capabilities in via an internet platform. We have looked into this and have published, and this is just a few, just mentioned in this slide, and came across with the concept of the expanded activity index, which predicted with more accuracy those plaques that could have developed symptoms. Well, so we now know what is the high-risk lesion. And we have other tools that seem to confirm that some lesions have a higher risk of developing stroke, like the very severe stenosis, the evidence of cerebral embolization on TCD, the presence of hypervascularization with contrast-enhanced ultrasound, and in those patients when it is possible to measure autoregulation, the loss of autoregulation. And we need to compare all these studies to find a single tool that could be a marker of the highest and high-risk lesion. And we have also more sophisticated methods to study plaque morphology based on biological imaging, from magnetic resonance to PET scanning, which perhaps would justify a study comparing the easy-to-perform, simple, cheap ultrasonographic technology with these new sophisticated tools. The other point that we wanted to address, and I think I will give you some information from the study, was related to the progression of disease. Professor A.Halliday did not mention in her presentation that there is a group within the ACST that that has a higher risk of developing ipsilateral symptoms when there was a severe progression of the disease. Not a very important, perhaps not a very significant group of patients, but an increase of risk of stroke of ipsilateral events from 3.4 to 8%. Well, from the ACSRS database, it came an information of interesting information. For me, it's a bit of a surprise that this was the progression of the disease seemed to be related to elevated creatinine, low GSM, severe ipsilateral stenosis, and severe contralateral disease, and with males. But the important data is that they showed that the plaques that had no changes or had a regression, they did not have symptoms. They did not develop symptoms. And those who had progression, they had an increased risk of symptoms. So progression was not significant when compared with plaque morphological studies, which allowed stratification on the basis of an annual risk of stroke varying from 1 to 10%. And I would expect a different conclusion. So, yeah, just a moment. So what about optimal medical treatment? We don't know yet the complete effect of the optimal medical treatment on the plaque structure. There is information suggesting that statins increase the echogenicity of plaques and maybe stabilizing the plaques. This probably would be an interesting area of investigation also. So, ladies and gentlemen, we need to identify a higher risk group of patients, and it seems that this will be possible with the available technology with an increased risk greater than 6% per annum. And we also know whose patients we should not treat. And those elder patients, insulin-dependent diabetes, dialysis dependence, and severe contralateral symptoms, they have a very low life expectancy, so probably should not be treated. The question is, could the new studies fill the gaps and the areas that need to be clarified? I don't think the ACST2 will address the real issue of the selection of patients, but it will provide undoubtedly confirmation that adequate carotid intervention will have a durable effect on stroke prevention in properly selected patients. So I would like to end up my presentation saying that we need to improve the criteria for selections in those patients with asymptomatic carotid stenosis, and perhaps the future trials and registries should include studies of the plaque structure and also to have an objective assessment of the effects of the optimal medical treatment. Thank you.
We are running pretty short of time. I just thought I'd take a quick straw poll to see who actually does these, uses these selection criteria. So who operates on patients only who have 80 to 99% stenosis? Okay, thank you. Who only operates on patients using echolucent juxtarenal black areas, or the black area of the plaque? Who does MRs to look for the black area of the plaque? In addition, who does the test to help make the selection? Okay.
Same group, the same old guys.
Okay, but who actually does GSM?
It's automatic these days.
Okay, but they're not using it. And who does MR plaque evaluations of any sort?
Can I just...
I haven't quite finished. You have to let me finish. Who does TCD to see if there are emboli? And lastly, who looks for loss of autoregulation to help them make the decision?
Sometimes.
Okay, so I guess the answer is that stenosis, overwhelmingly, is what people are actually basing this on, which is curious.
It is. Can I reply? It is curious, but
Very
the
curious.
fact is by using perhaps these plaque morphological studies, we were able to reduce the amount of asymptomatic carotids that were operated in my unit. In my unit, we did 70%, until a few years ago, 70% of carotids operated were asymptomatic. These days now it's 40%.
Yeah,
We are
but
reducing
the
that.
curious thing is that you talked about the stroke risk and what stroke risk people would consider sufficient. And actually the stroke risk from trials, bigger trials, is almost identical whether you have a 60, 70, 80 or 90% stenosis. The risk is pretty similar.
I think it is worse. In the Conrad study has shown that it's very higher risk of those patients with very severe stenosis, which even on optimal medical treatment, they have a very higher risk of stroke.
Thank you, Professor Fernandes. So another presentation is about Matsagkas from Greece. Is stent cells design affect outcome after carotid artery stenting? Please, Miltiadis.
Mrs. and Mr. Chairman, dear colleagues, I have to thank from the podium the organizing committee and personally my friend Lazar Davidovich for this kind invitation to be here. And I have nothing to declare according to the topic. As Steve Jobs said, design is not just what it looks like and feels like. Design is how it works. And we all know that the stent design in the carotid territory changed a lot during the last 10 to 15 years, and we have a lot of designs coming from different manufacturers. But we all categorize these stents in two major categories: the closed cell design, that these stents are less flexible, less conformable in tortuous anatomy, but they have lower free cell area and also have a better scaffolding. And on the other side, there is the open cell design category with a more flexible stent, a more conformable stent, but with a higher free cell area and less better scaffolding. Of course, we have the hybrid design with cells like the Cristallo stent with open cell at the edges and closed cell in the middle of the stent. And in terms of flexion and conformability, we all know that the open cell design is a better design to conformable to the sometimes tortuous anatomy of the internal iliac artery. And you can see in the slide that the closed cell design has a rigid approach after the implantation. Quite opposite, the open cell design has the tortuosity and looks like the natural anatomy of the internal iliac artery. The crucial thing about the stents design is that are not all stents the same. This is having no light. And you can see that in these two different groups we have several stents with different free cell area, and this different free cell area can go from the wall stent that has the smaller cells up to tenfold to the AccuLink stent that has the most open cells in this design. And in the particular, if you can see in the border of these two groups, you can see some stents that are quite close according to the free cell area of their design. Coming to the literature, the last few years, you can see articles like that published last year in Journal of Vascular Surgery that found that the macroembolization from these stents could be, in terms of numbers, bigger in the closed cell design, and this is quite non-expecting, and while in the mean size of particles were, of course, larger size in the open cell design. And we have other studies showing to us that the microembolization after the procedure, the carotid artery stenting, can be double in the open cell design. But is this true? Because we have other studies, and this was a randomized clinical trial, that the authors concluded that there was no difference between these two cells design according to the microembolization. The most crucial thing in these studies about microembolization was that the adverse events in all these studies was not significant difference between patients with different stent designs, implying that these clinically silent embolic lesions do not affect the neurologic outcome of the patient. And then we have to study what is in the literature about the clinical outcome according to the stent design. Here we have also conflicting results. This study came up in 2007, said to us that in the open cell design we have double the neurologic events after the procedure in comparison to closed cell design. But another study 1 year after that find that there was no significant difference between these two groups according to the clinical outcome. Based on that, last year we decided to do a meta-analysis of the literature and identified at last 9 studies from 2007 to 2013. 6 of them were retrospective, 1 registry, and 2 prospective studies, coming up to almost 8,000 of patients. This meta-analysis was published last year in the Journal of Endovascular Surgery. Interestingly, in this meta-analysis, half of the patients were in the group of open cell, and half of them was in the group of closed cell design, and the symptomatic patients between these two groups were quite equal. According to the use of a filter or an EPD, these studies was almost identical, and also according to the use of pre- or post-dilatation of the lesion. Where the documents and the data were very poor were in the indications for treatment, and out of these 9 studies, only 2 studies gave detailed data about the indication, how many patients were symptomatic in each group, etc. The results of this meta-analysis was that the 30-day mortality was almost equal and, of course, not significant. Even it seems that favored the group of the open cells. And according to the neurological outcome, the 30-day TIAs, the 30-day strokes, and the combined neurologic outcomes was almost identical between these two groups. If you add on this and the death rate, also the result was not changed. So it seems with the currently available data that there is no matter of the design of the stent to the clinical outcomes of the patients. Of course, there was limitations in this meta-analysis regarding to the quality of data of the original studies. And for example, in my mind, a lot of stents were used in these studies, a lot of different stents with a different free cell area. And of course, the future of the stent design is here. We have meshes now combined with bare metal stents, even though some believe that this meshes may be more thrombogenic than the simple stents. So in conclusions, ladies and gentlemen, there is a continuous refinement in carotid artery stenting techniques based on selection of different endovascular devices for varying anatomic and plaque characteristics. The selection of the stent design could be incorporated, of course, into carotid artery stenting treatment planning, but the currently available data shows that 30-day cerebrovascular complications after CAS are not significantly different for this open cell group against the closed cell group. And of course, head-to-head randomized comparisons between stents of different designs are welcome, but it's almost impossible to be performed since it requires a quite large number of patients, and we all know what happens in the carotid clinical trials nowadays. So my tailored approach to this patient is to use a closed cell stent when the main issue is the lesion coverage and the prevention of embolization, and of course to select an open cell stent when anatomical features like tortuosity or significant tapering clearly play a stronger role in decision making. Thank you very much for your attention.
Thank you, Mikhail. The time is few. There is only for a short question for the audience. No question? Yes, one.
Thank you. Nice presentation. Just a quick comment. The importance of microemboli on MR scans are not yet clear. I do accept they're not associated with an immediate effect on neurological outcomes, but they cannot be a good thing, and it is possible that they do predispose to cognitive decline in the longer term.
I agree with you, but at the moment we don't have any sufficient data to support any conclusion on that.
Okay, thank you, Miltiades.
So I call upon Professor Davidovich. Thank you.
Ladies and gentlemen, dear friends, dear colleagues, this was supposed debate about neuromonitoring in carotid surgery, debate between two great vascular surgeons as well as two friends. Again, in Italian derby, that unfortunately will not be happen. Namely, a couple of days ago, our friend, our colleague, Professor Giustino Marcucci, left us unexpectedly. We didn't change the scientific program. Namely, we would like to want his name to remain in these Congress's documents in the same manner he will remain in our hearts forever. So, allow me to invite all of you to honor our friend, our colleague, by a minute of silence. Thank you so much. May rest in peace, our friend.